easiest way for me not to.
Okay, let's go ahead and get started. We're going to take a look today at the beginnings. We're going to introduce you to the general senses. This is starting Unit 4 of Lab, and we'll culminate Lab in about 3 or 4 weeks with brain dissection and eyeball dissection. So why don't you take a bite of something? So, yeah, no, it'll be a lot of fun. The section of the brain and the eyeball are always very, very, very interesting to see how things function. So, okay, let's. Anybody have any questions on anything before we get started? Okay, then let's go into this. I'm going to open this up and go into this from eLearn. Yeah, There we go. Okay. Now, our ability to be aware of everything going on around us and inside of us depends on sensation. We have to be aware, either consciously or subconsciously, of changes in our environment. If you complain that it's too warm in here, you're aware of your environment. If you complain that you're too cold, you're aware of your environment. You know, if you put your hand down on something hot or something sharp, you're aware of it. If you hear a sound, you're responding to a stimulus from the outside. If your side hurts, if your bladder is full, if you're hungry, if you are thirsty, you are responding to a stimulus, but that's an internal stimulus. So the ability to detect a sensation is telling us what's happening both inside our bodies and outside our bodies with our internal environment and our external environment. And it isn't enough just to be exposed to a stimulus, because a stimulus, all a stimulus does is activates a receptor. A receptor on your skin, or a receptor in your blood, in your blood vessel, or a receptor in your urinary bladder, or a receptor in your mouth. The first thing that happens with the stimulation is we have to activate a receptor. Now, is the stimulus strong enough to turn on the receptor? That's an important thing to consider, because sometimes the stimulus isn't very strong. Sometimes the stimulus is very gentle and we don't even pick it up. We have a range of hearing that changes over time. We have a range of hearing from what we call the low sound. I'm trying to think of the word for dealing with decibels, but we have low end sounds and high end sounds. And as we age, we start losing the edges of both the low end sounds, so the low deep sounds, and the high pitched sounds. We start losing both of those. And so someone who is 20 may be able to pick up a sound that someone who's 80 can't, because a person that is 80 years old, the stimulus isn't powerful enough for them. How many times have you encountered somebody who is, as we like to say, hard of hearing, and you have to talk louder to get them to understand what you're saying? And they talk louder to you because they can't hear themselves either. You know, we've all encountered that. So our sensory receptor has to be stimulated. It has to receive a stimulus, and it has to generate a nerve impulse that it's going to send to the brain. Sensory receptors don't tell us anything about what we're being stimulated by. A touch receptor on your skin, if I'm pressing the tip of that on that giant hair follicle there, or hair shaft, and it's pointy and it's a sharp point, you know, the touch receptor in my finger, the pain receptor in my finger, doesn't tell me that it hurts. All it's doing is being stimulated. Receptors don't tell us anything. We have to process inside our brain to know what it's doing. Our eyeballs have no idea what they're seeing when light rays come in. Light rays stimulate the retina, generate a nerve impulse. We call it an action potential. And you're probably going to hear all about action potentials in lecture on Thursday in muscles, but an action potential is the same. The nerve impulse coming from the sensory receptor going to the brain is identical to all other nerve impulses. They're all the same. They're no different. What's coming from the eyeball or coming from a touch receptor on your finger, or a nasal receptor in your an odor receptor in your nasal cavity, or a stretch receptor in your urinary bladder, those signals all look exactly the same. It's how they're interpreted in the brain that tells us what they are. So we don't confuse looking at a stop sign with having to pee, because the signals are exactly the same. But where they're being received in the brain is telling us what they are. And then not only do we know what the signal is in the brain tells us what we have to do. When we see a stop sign, there's a variety of things that we do, which may or may not be legal, but we still make decisions about stop signs or yellow lights. Who hasn't made a decision about a yellow light recently? So you look guilty. So now we have to make our sensation is received by the sensory receptor, which generates a nerve impulse, which goes to the brain, and that tells us what the sensation, the stimulus really is. Is it a sound? Is it a taste? Is it an odor? Is it sight? Is it pressure? Is it pain? Is it temperature? All of these things are going to have to be interpreted because our brain knows what they are. The receptors have no clue. It doesn't matter how sophisticated the receptor is, whether it's the eyeball or the ear or the nasal cavity or just a plain old little touch receptor on the end of your finger. None of them know what's going on. They all have to be interpreted by the brain. Sensory receptors are designed to respond to a stimulus. That's all they are. They have to stimulate, the sensory receptor has to stimulate the nerve, the neuron that they belong to, and the neuron will generate a nerve impulse, what we call the action potential, that will travel to the brain. Perception only takes place in the brain. Sensation takes place at the nerve, at the receptor. Perception takes place in the brain. And we put, the brain takes the input from the sensory receptor, whatever the receptor is, and then interprets it. So we perceive it. We perceive the odor, the sound, the smell. I guess the odor and smell are the same. The odor, the sound, the taste, the touch, the pressure, the pain, the temperature. So now we have a variety of receptors on our bodies, and they respond to many different types of stimuli. They're located in different parts of our body, and some are very complex and some are very simple. Now, this is your basic part of any sensory receptor. This door keeps coming over and I keep walking into it. This is a neuron. This is the heart of any sensory receptor. Now, these lines up here are fibers. These fibers are called dendrites, and they are the receiving end of a neuron. Your sensory receptor is going to be somewhere at the end of the dendrite. And the sensory receptor will send a signal to the neuron, to the cell body. And then if the signal is strong enough, if the stimulus has been great enough, the cell body of the neuron will send the signal down the axon. So this is the axon. Every cell, every neuron, every nerve cell has an axon. The axon extends from the cell body and signals go down the axon one way. They go from the nerve cell to the brain. It's a one-way passage of information. And once those signals, those nerve impulses start running down the axon, they don't stop. They don't wear out. They don't fade away. They don't stop until they get to either another neuron to send it on its way or to the brain. There's the cell body. It's the nucleus. And there is the dendrite. Now, the dendrite connects to the sensory receptors. Some sensory receptors are just the end of the dendrite. The signal, the stimulus of the sensory receptor may not be strong enough to get to the cell body, in which case we don't feel it. we may stimulate the sensory receptor for touch, but not be aware of it. If someone comes up behind you with a feather and starts touching the back of your neck with a feather, you may not be aware of it because you're activating a touch receptor with that feather, but the signal isn't strong enough to get to the neuron, and it fades away. The nerve impulse that comes from the sensory receptor to the cell can fade away. That one depends on the intensity of the stimulus. The one that goes down the axon never goes away until it reaches its destination. So, sensory receptors, the general senses, are both somatic and visceral. The somatic sensations, touch, that's tactile. That includes itch and stretch and pressure, for example. So tactile, thermal, that's temperature. Pain. Pain is our body's way of saying, don't do that. It hurts. So, because we always say if it hurts to do something, we don't do it. And proprioception, big word. It means our position in space. Where's my right hand? I don't have to look up above my head to know it's up there. Proprioceptive receptors tell me that my right hand is up behind the back of my head. So we are aware of our body, the location of our body in space. So these are, somatic generally means surface type sensors. Visceral tells us what's going on the inside. It tells us our blood pressure. It tells us our body temperature. It tells us our salt concentration. It tells us, our oxygen levels. It tells us all sorts of things. It tells us if our bladder is full, if our heart is working properly. Does our heart hurt? Is our gallbladder working properly? Do we have a kidney stone? Are the muscles sore? Things like this. Anything internal, the viscera, we detect that way. Do we have a temperature? Do we have a fever? That's sort of a two-way sensation because we detect that. You can detect that in the surface of the skin, but it's also internal too. So those are all the general senses, both somatic and visceral, on the surface of the body, within the body. Now, the general senses are different from the special senses. The general senses, the sensory receptors can simply be the end of a dendrite. But the special senses are unique. Excuse me. The special senses, there are 5 of them: smell, taste, vision, hearing, and balance, or equilibrium. The need to cough is not a special sense. So the special senses are found in specialized sense organs, all located in the head: hearing, vision, odor, taste, and balance. So they are all located in one area. The general senses are scattered throughout, both internal, and external. Okay. So what kind of receptors do we get? Well, we have mechanoreceptors. These are mechanical receptors. And they can be both internal or external. Mechanical receptors detect pressure. They detect touch. You are deforming the end of a dendrite, so you're aware of a stimulus. Someone touches you, or you touch something, and you can identify the shape of it by its touch. Mechanical receptors detect distortion. We have mechanical receptors in our large arteries that detect blood pressure. They detect changes in our blood pressure. We have mechanoreceptors that detect changes in the air pressure in our lungs so that we know when to expand and relax. We detect pressure in our urinary bladder and in our large intestine. We detect pressure in our small intestine when we've had some inappropriate choices of food, particularly like if you like cooked cabbage, lots of cooked cabbage. If you don't know what cooked cabbage does to you, it generates a lot, as it breaks down in your digestive tract, it produces a lot of methane gas, which causes bloating and discomfort and what we call flatulence. So lots and lots of flatulence. So again, but that is a mechanical distortion of the small intestine. So the pressure and discomfort you might be feeling in your small intestine after having 5 bowls of cooked cabbage one day and a couple bran muffins just to throw in on top of it, which makes your existence that day very tenuous. You're going to feel a lot of discomfort because of the pressure of the bloating in the small intestine. Now, thermoreceptors deal with temperature. We have different sets of temperature receptors for heat and for cold. They they are unique to detect the receptors that detect temperature increases, like when it's too warm in here, are different from the ones that detect cold. Now here's the one with a strange name, the nociceptors. These are the pain receptors. Pain receptors are unique. Pain receptors are designed to warn us that something is damaging the tissue or the skin or the internal organ. Pain is our body's way of sending us a warning. And sometimes we can depend on pain to warn us in the right location, and sometimes not. Sometimes the pain receptors fool us and we get signals from other parts of the body instead of the area that's being affected. So we have photoreceptors found only in the eyeball. The only place we can see things is in our eyeball. And then all we're getting is light rays coming through the lens into the hitting the retina, generating a nerve impulse that is unique to what we're looking at. Again, though, the eyeball has no clue of what it's seeing. It's just like the camera on your phone. You take a picture of something. Does the camera know what you're taking a picture of? Has no clue. It just collects all the light, the images, the photoreceptors in the camera, same principle, collect the images, put together a comprehensive picture. It stores it in your phone as a series of digital images. It has no idea it can tell you when it was taken, but it can't tell you what it is. So our eyeballs are the same way. We still have to interpret in our brain what we're seeing. We still have to interpret the picture on the phone of what we're seeing. So chemoreceptors detect chemical changes, both internally and externally. For example, odor, detected by what we call olfactory receptors in the nose. Odor depends on molecules of a substance drifting through the air, moving into our nose and getting stuck on an olfactory receptor that we can stimulate. Still doesn't know what the odor is. Our nose can't distinguish between something unpleasant and something pleasant. The brain can, but we activate the olfactory receptors at the top of the nasal cavity. They go up through the olfactory nerve into the brain, and then we know that it's pleasant or unpleasant. We say, oh, that smells like a rose, or that smells like garbage, or whatever. Or you can tell when your dog had an accident in the middle of the night, as the rather pungent odor that drifts through the house. You can identify that. Chemoreceptors do that. Our taste buds are the same way. They are chemoreceptors that detect sweet and sour and sugary and salty and flavors like that. The changes in our blood that occur when we exercise, when our blood becomes more acidic or more basic, is also detected by chemoreceptors in here. And then the Osmo Receptors, they monitor salt concentration. Our bodies are about, well, the normal saline, normal plasma in our blood's about 0.9% sodium chloride. And that never really changes. The actual amount of salt in our bodies doesn't change. The volume of water can change up or down. If our salt concentration drops in our plasma, for example, our salt concentration will drop if we're retaining water. The actual volume of salt hasn't changed. The actual amount of salt hasn't changed. It's become more dilute because we're retaining more water. If we see a rise in the salt concentration in our bodies, it's usually always because that the water level has dropped. I mean, consider you got a beaker. I'll go back to my beaker analogy. You got a beaker of water. I put 100 grams of salt in a liter of water. That's a 10% salt solution. Have 100 grams in there. If I let half the water evaporate, now I have 500 milliliters of water. Do I still have 100 grams of salt? Yeah. The salt hasn't gone anywhere, but now the salt concentration in a half a liter of water is still, I still have 100 grams of salt, but now in a half a liter of water, that's a 20% salt solution because I've taken away half the water. And if I were to take that liter of water with 100 grams of salt and add another liter of water to it, I'd have 100 grams in 2 liters. Now I'd have a 5% salt solution. So in our bodies, if our salt concentration goes up, it's because our water level drops. We don't monitor water because it'd be hard to monitor every cell in the body, but we can monitor salt pretty easily in our plasma. And if we monitor the salt concentration, if it goes up or down, our first response is we get thirsty or we don't get thirsty. And so we know how much water we have in our bodies at any given time by monitoring the salt levels. So they're a very special type of chemoreceptor. And this is a real hard-hitting point here. If the receptors are exteroceptors, they're on the surface. If they're interoceptors, they're internal. The proprioceptors are sort of an unusual one. They are found in our muscles and in our tendons and in our joints. So while they are technically interoceptors, they are a whole category of sensory receptor location. No other sensory receptors are in, no other category fits that definition. So there are special receptors in muscles, in the tendons, and in the joint capsules themselves. Okay. Now, if you are a sensory receptor, as I said, you're either going to be a simple receptor or a complex receptor. Even if all the general senses are simple receptors. All the general senses are simple receptors, or they are nothing more than the end of a dendrite. They are an end of a dendrite. That's all they are. They can pick up any kind of tactile stimulus. They can pick up temperature, pain. They can even the proprioceptors are nothing more than the ends of dendrites. It's only the special senses that have the very complicated sensory receptors, and all of those show up in sense organs, special sense organs like the eye and the ear. The point I'm trying to make is that most of our sensory receptors in our bodies are simple. And all the simple ones are nothing more than dendrites. Dendrites, they may be a free nerve ending with just the dendrite there. They may be modified slightly, but that's all they are, is dendrites. So most of our sensory receptors are all dendrites, since most of our sensory receptors are simple. Now, tactile sensations. Tactile sensations, I've talked about this a little bit. Touch, pressure, vibration, itch, and tickle. These are all detected by dendrites. These are all simple. don't get touch confused as one of the special senses. It's not. Every semester I get somebody marking down touch as one of the special senses, and it's not a special sense. So, and every semester I stand up here and say that too, and somebody still does. So, yeah, well, because you'll overthink it. You'll overthink it. That's what happens. They overthink the question. So now the tactile receptors in our skin, we have receptors that are right underneath the epidermis. Now the epidermis is mostly dead cells, but underneath that we have the dermis, and right at the edge of the dermis and epidermis we have we have a variety of different types of receptors. We have what are known as Meissner's corpuscles. We have hair root plexi. We have the Merkle Disc, the Ruffini corpuscle, the Pacinian corpuscle, and the free nerve endings. Now let's take a closer look at some of that stuff here. Let me go down here a couple slides. There we go. The Merkle disc, the tactile disc, is a mechanoreceptor near the surface of the skin. It is located right at the juncture of the epidermis and the dermis. The epidermis, of course, is the area, the outer layer of our skin, which is mostly dead cells. Once you get down towards the dermis, you get a layer of living cells, but everything above that bottom layer of the epidermis is dead. Now we see the Merkle disc where we're going to have sensitivity, where we want to have discriminating touch. See if I have it on this model here. So, okay. So there's where you see your Merkle disc. Adjacent to it, you have the Meissner corpuscle, which is also another touch receptor. Way down here at the bottom, you have a Pacinian corpuscle. This is what's known as a encapsulated ending. This is nothing but a dendrite with a layer of connective tissue around here. We use that to detect deep pressure. And one that we're all familiar with without even thinking about it is what's known as the hair root plexus. That is a dendrite ending wrapped around the shaft of a hair follicle. And that allows us to detect the movement of our hairs on our skin. When air moves across, for example, and we're aware of that, we start feeling cold. We get air movement across our skin, perhaps, or when we brush up against something and we stimulate the hair follicles, it is the hair root plexus that's telling us, hey, I'm moving my hair follicles. This is something is stimulating them. So it probably doesn't take that long to figure it out though. So now let's go back here. If you are a dendrite, and most of the sensory receptors in our bodies are dendrites, other than the special senses. The sensory receptors, the dendrites, are either going to be encapsulated with connective tissue or non-encapsulated. If you are non-encapsulated, you are just the end of the dendrite. And so you just stick the end of the dendrite out there and you can be stimulated constantly. The encapsulated nerve endings are wrapped with connective tissue, and they take a little more stimulus to respond. They're also deeper in the dermis. The free nerve endings are all over our skin in a dermal layer. They're in connective tissue. They are going to respond to temperature, and they're going to respond to pain. This is really important because you don't want anything to get in the way of being able to detect pain. They respond to light touch also. Gentle touch, the free nerve endings. The encapsulated nerve endings, though, are going to be deeper. the encapsulated nerve endings are going to be deeper in the dermis, almost down to the layer of the hypodermis, because the hypodermis layer is where the fat starts to show up. The Meissner's corpuscles, for example, and the Merkle disc are, well, the Meissner's corpuscles are just below the surface of the skin in the dermis. Now, we find the Meissner's corpuscles in the area of our fingerprints. Our fingerprints are formed by structures called dermal papillae, and they look, this I can show you. If I can get this thing to work. Let's see. I'll use this instead because I know how this one works. Okay. Stop sharing here and go to a different camera. There we go. Okay. This is the surface of our skin right here. You can see it right here. These little bumps over here are what are known as dermal papillae. Now, they don't look like much on this model, but they represent the ridges and the loops that we find in our fingers. They are at the surface of the dermal layer, and these little bumps create the ridges that you see in your fingerprints. You know, if you've ever had your fingerprints taken for whatever reason, you see where all the lines are. And that's what these ridges, these bumps here form. These are the dermal papillae. And directly underneath here are going to be that structure that we were talking about. This is a Meissner's corpuscle right here, discriminating touch. When we rub our finger over something, we can tell if it is a rough surface or a smooth surface. This is a Meissner's corpuscle. There's another one next to it. They are right in the area of the dermal papillae where our fingertips are. This is some of the most discriminating and sensitive tissues in our body. They allow us to very easily determine my camera. They let us very easily determine the difference between soft surfaces and smooth surfaces. I want to turn it on. There we go. Okay. For example, if you know anything about sandpaper, sandpaper comes in various types of grit. We start out at about 60 grit, which is a very rough surface. You use that for taking the edges off of wood or metal, and it does a really good job grading off the surface, and it makes the surface of the wood smooth. But that's not good enough because you can get it even smoother. You can use, you go from 60 to 200 or 220, and then you sand your wood down and it gets very nice, very, very smooth. It takes out all the imperfections. You can rub your finger across there and wow, that is so much smoother than the other one. The other one now feels like it's, you know, you're rubbing your hand across concrete. But then you can go to 600 grit. 600 grit makes it feel like glass when you sand wood down with 600 grit. And you rub your hand across the surface, and now it is like rubbing it across, you know, like I said, like glass, like, you know, it's just, as they say, smooth as silk, if you will. The difference in the various types of sandpaper. Now, if you were to take the sandpaper and rub your fingers across the surface of the sandpaper, the 60 grit is very rough and abrasive. The 220 is still abrasive, but it's not very rough. You can tell there's something in the paper. The 600 grit is almost like rubbing across regular paper, like, you know, you get it out of your printer or something. You can't even feel the distinction there because the dermal papillae aren't sensitive enough to detect the imperfections, the abrasive surface in that type of sandpaper. So maybe I'll remember to bring some in next week and So let's, come on. Here we go. Let's back to share screen. And okay, so this Meissner's corpuscle, right at the surface layer between the dermis and the epidermis, right in the fingerprints. The fingerprints are called the dermal papillae. And in our most sensitive areas of our body, we're going to have lots of Meissner's corpuscles. We also have the Pacinian corpuscle, which is deep inside the dermis, almost to the hypodermis. That responds to deep pressure, and vibration. You get a deep tissue massage, for example. You are sitting on in a very uncomfortable chair for a long period of time, and the pressure on your butt is pretty intense. So your Pacinian corpuscles are going to respond to that. Now, and so your Pacinian corpuscle, right here near the hypodermis, is the hypodermal layer, is where we find most of our fat cells. Here's our Meissner's corpuscle here. Here is a Merkle disc that is unencapsulated, by the way, because there's no connective tissue around it. Now, thermal receptors. So we've seen the different types of tactile receptors. Let's take a look at thermal receptors. We are sensitive to both cold and hot. They are embedded in our skin, embedded in our organs, and they will respond to changes in temperature. And they will continue to report until we move out of their range. If we go from cold to warm, the cold receptors will stop functioning and will essentially shut down because they're not needed, because you moved out of their temperature range, and then the warm receptors will kick in. If you go into the extremes, you'll destroy them. If you go outside their range, if your cold receptors are exposed to extreme cold temperatures, you can destroy the temperature receptors. For example, dry ice. Anybody ever play with dry ice? You can fess up, it's okay. Dry ice is something solid, frozen carbon dioxide. It's great for demonstrating extreme cold. It's great for generating carbon dioxide gases. It's what shows up in every horror movie when you want to have bubbling test tubes and stuff without doing anything. You throw it into a beaker and it foams and it bubbles and it looks really cool, because it is really cool. It's cold. If you were to pick up a hunk of dry ice, it is so cold that it would exceed the cold receptors range of operation in your skin, and it would destroy them, and you would have frostbite. You'd essentially burn your fingers to where the skin is damaged and the temperature receptors no longer respond, and then it would start to hurt. When we go past the extremes, the extreme end of the range for temperature or for cold, we very quickly we activate the pain receptors. Just like something hot. If you were to put your hand down on a hot surface accidentally, it would very quickly, it would stimulate the temperature receptors and very quickly destroy them and move into the range of it hurts. The pain receptors would be activated. So either way, either extreme cold or extreme heat, we don't do well with either one. Now, the pain receptors. Pain receptors are pretty unique. They are free nerve endings. They don't want anything in the way of telling us it hurts. We call them nociceptors. They are not a special sense or just a regular general sense. They are a free nerve ending. They warn us that something hurts so we can stop doing it. Because that's what they're doing. They're saying, it hurts, don't do that. It tells us that we have tissue damage, or it tells us we're gonna have tissue damage. You put your hand down on something on a hot surface and you yank your hand back immediately because it hurts. If you yank your hand back quick enough, you may not have hurt yourself. The stimulus to activate a pain receptor is going to be pressure. It's going to be temperature. It's going to be histamine. Histamine, why histamine? Well, histamine is a chemical that our bodies release when the histamine receptors are stimulated. Histamine receptors respond to irritants and allergens. So if you're allergic to pollen, and pollen drifts into your nasal cavity, which it does, and in a few weeks, all the pine trees are going to be letting go with all their pollen. Our cars are all going to turn yellow. So our bodies respond by releasing histamine. The pollen lands in the histamine receptors. We release histamine. Histamine causes our blood vessels to dilate, to become very permeable, and allowing the plasma to leak out and become interstitial fluid. And what it does is it's washing away the inside of our nasal cavity. Our noses run because of this. We're trying to wash out the irritant. Our eyes water, trying to wash away the irritant. Our nasal cavity tends to become congested with all the mucus that we're forming, which was interstitial fluid earlier. And we feel miserable. Our nose is swollen and puffed up, and our eyes are all red and watery, and we have a lot of pain because when we create leaky blood vessels, plasma leaks out into the tissues, and before it goes out and dribbles out our nose, it puts pressure on pain receptors in our nose and in our eyes. Now, if it's a systemic effect, if you're allergic to peanut butter or seafood, maybe you don't like peanut butter covered shrimp. I don't know. Let's say that you are allergic to peanut butter, shrimp, and bee stings, and so you're eating a peanut butter covered shrimp while you get stung by a bee. So we've covered pretty much all bases here. Oh, and you've been exposed to pollen, but the pollen's not a big deal. A food allergy or an insect venom allergy causes what's known as a systemic problem. It isn't just a localized, like a runny nose. A systemic problem causes a massive release of histamine. And we flood our bodies with histamine, causing a massive amount of fluid to leave our blood, go into our tissues, and we swell up. You've always probably seen pictures of someone swelling up after being stung by a bee or eating shrimp or something like that. Well, it's true. I've seen pictures of someone whose head doubled its size because it's swollen. It hurts. It creates a lot of pain because you're pressing up against pain receptors. So there's all sorts of things that can stimulate us for pain. It isn't just hitting your thumb with a hammer. The thing about pain receptors is they never adapt to pain. Lots of receptors adapt. We get used to the stimulus in some things, but pain receptors never adapt. We never get used to pain. We can live with pain, we can mitigate pain, but we never get used to it. Because if we got used to it and it became sort of like a background stimulus, we wouldn't pay attention to it. So we don't adapt to pain. Now, pain comes in two types. It hurts or it really hurts. Now, it is fast pain or slow pain. Fast pain is like when you cut yourself, you're cutting up vegetables and you cut yourself, or you're playing with your dog and your dog tries to demonstrate once again that his claws are sharper than your skin, so that was this morning. So, and it hurts for a little bit. That's an acute pain, No, I didn't show you that. That was just, I said, when he got me this morning, hey, I can use that as an example in class of pain, because it really hurt for a few minutes and bled like crazy, but that's beside the point. The point is That's fast pain. That's short-term pain. It's sharp. It's like a paper cut. You know, we all know how much fun paper cuts are. You know, slow pain is chronic pain, nagging pain, backache, kidney stone pain. You know, anything that is long duration, a deeper pain, a throbbing pain, heart attack pain is going to be chronic pain. Collapsed vertebrae is going to be chronic pain. You know, so all these are going to be the slow pain that your patient lives with. You know, so fast pain, sharp, acute. You step on something sharp accidentally. You put your hand on something hot, yank it back. Again, that's short-term acute pain. Chronic pain, sore back, kidney stones, something like that. Now, two types of pain, visceral and referred. Visceral pain comes from the viscera. It comes from, you know, when you have a patient that has acid reflux and it burns in their throat, or if they have appendicitis, or if their gallbladder is acting up, or if they have a kidney stone that's moving down the flank here to the bladder. That's all visceral pain. It can be caused by sore muscles. It can be caused by not enough oxygen getting to the heart, for example. That's ischemia. The muscles have been stretched more than they should be. All of these are going to be visceral pain. And so you have pain. Your appendix hurts, you should have pain in the lower right quadrant. The gallbladder hurts, you should have pain in the upper right quadrant. You're having a heart attack, you should have pain in the middle of your chest.
What happens when a patient has SIBO?
Is what?
SIBO, where they can't feel pain, like they don't feel pain.
Oh, yeah, that's okay. Now that's a good point. You know, yeah, and you get a version of that with your diabetic patients having what we call neuropathy, where they have poor, not only do they have poor circulation in their extremities, but they have poor conduction of nerve impulses in their extremities. They don't know that their leg is infected because they can't smell it, they can't feel it, or know that they have something going wrong because it doesn't hurt. They don't. The nerve impulses aren't being connected there. The only way they know they might have a problem is they smell. So if they can't sense pain, then individuals like that have to be much more careful with injuries and things like that. You know, we've all experienced at some point where we've cut ourselves and we're bleeding. And we don't like, well, where did that happen? You know, we see that all the time. We do it to ourselves like, oh, you know, we didn't notice it. Imagine what it's like to have that as a constant thing, where the only way you can know that you're injured is when you see the blood all the time. You know, and so your patient there, you know, someone who's having a heart attack, for example, is going to have a lot of other symptoms than just pain. And even then, pain is not always a reliable indicator that there's a problem. You know, if you're gonna feel, you know, a person who's having a heart attack and is not experiencing any pain, and some people do experience that, there will be other symptoms. There'll be shortness of breath. There might be nausea, there might be vomiting, there might be dizziness, a racing pulse, for example, or an irregular pulse. You know, any number of these things. Sometimes people that experience a heart attack with no pain just say, I don't feel right. But shortness of breath is all, you know, since the chest pain isn't going to be there, the shortness of breath may be a good giveaway too. So it just makes it harder to try and diagnose. Because, and even if they don't have a problem with pain sensations, our bodies like to play these games with us. We have what we call referred pain. referred pain is when we sense pain from another part of the body, but that's not where it's coming from. Referred pain can occur from the gallbladder. Okay, your gallbladder sits right here, right underneath the ribs. On the right-hand side, it's underneath the liver, and it should be very easy. You got a lot of pain right here in the upper right quadrant. Oh, it must be the gallbladder. Well, the gallbladder decides that sometimes the pain's going to be on the right shoulder, up here. Sometimes. Well, the problem with pain in the right shoulder is, okay, that's pain in the right shoulder. It must be the gallbladder because we're getting some referred pain. Well, you also get right shoulder pain for pneumonia. You also get right shoulder pain from a heart attack sometimes. And sometimes it's just a sore right shoulder. Sometimes a pain is just a pain. We don't always trust where the pain is located. We may know it hurts. See, what happens is that the visceral nerve fibers and the somatic nerve fibers, visceral pain coming from the visceral organs and somatic pain coming from the surface of the skin follow the same pathways. And so if you have pain in your skin, if you're having a heart attack, the pain coming from your heart is going to travel on the same pathways as pain from your muscles. And so your brain's going to think, oh, your muscles hurt. Because one of the classic signs of a heart attack is not just chest pain, but pain down the left arm. Your brain is saying, oh, I'm not having a heart attack. My left arm hurts. Sometimes it is just a sore left arm, but it's a very common referred pain phenomena with the left arm being sore. Not only that, the same nerve that innervates the left arm and the heart also innervates the lower jaw and the abdomen. So your patient could be presenting themselves in the emergency department with an incredible toothache on the left side of their mandible. And sometimes it is just a toothache. But that's also one of the locations that could be stimulated, innervated by heart attack pain, the lower left jaw. Who knew? It's not going to do your patient any good to send them home with some Tylenol 3 and they wake up dead the next day because they were having a heart attack. So you can't just assume that, well, it's just a toothache. Maybe it is. You can't assume it's just left arm pain. Well, maybe they were helping somebody move for 2 days and it really is left arm pain. Or maybe it's a heart attack. So we don't know. So referred pain doesn't always help us. A good example, if you've ever bumped your elbow, the ulnar nerve runs right underneath the olecranon process. And so when you hit the ulnar nerve and you get that tingling sensation in your hand, you hit your funny bone, but your fingers tingle. Why? Well, they're not tingling at all, but your brain thinks they are, because the same nerve pain pathways for your hand follow the one from the elbow. And so we've stimulated the ulnar nerve and our fingers will tingle. And even though we haven't done a thing to our hand, so that is referred pain. They follow the same pathways. The deep pain signals follow the same pathways, the same nerves as the surface pathways. And so we get a false report on where the pain is located. And the problem with trying to track it down is that you can't make that kind of assessment. You can't say, well, it's pain in the right shoulder, it's probably gallbladder. Well, maybe it is a pain in the right shoulder, but pneumonia pain and heart attack pain sometimes show up on the right-hand side. This is the chart of where referred pain generally shows up. The heart, for example, lower left jaw, all across the chest. on the left-hand side, down the left arm. You know, the gallbladder can be where it's supposed to be on the upper right quadrant, or it can be in the right shoulder. The appendix can be anywhere across the lower right quadrant, all the way to the midline. And I've actually seen it on people where it starts on the left-hand side and moves to the right side after a couple of days of inflammation. So it can happen. Kidney stones are a great example of referred pain. The kidney is set high up here in the back wall of the abdominal cavity. The ureter runs all the way down here to the urinary bladder, right here in the inguinal region in the pelvic cavity. That pain, that what they call flank pain, can be anywhere all the way across the back, down the side, across here. You can see that whole area lit up there in light blue is kidney stone pain or kidney pain. So it can be anywhere showing up. So the liver, look where the liver can hurt. Not just where it belongs underneath the upper right quadrant, but all across the rest of the right shoulder. Where the gallbladder stops, the liver picks up. You know, so how can you determine exactly where the pain's coming from? You can't depend on pain alone as your source. Now, you know, if their hand is crushed and it's bleeding out and they're screaming, it's probably a pretty good idea that their hand hurts. You know, sometimes it's obvious. Or they have a penetrating injury and it hurts. Sometimes they'll have a penetrating injury and it won't hurt. So pain's not always a good indicator of what's going on. Just a couple more points here for today. Our sensory receptors, many of them adapt to the stimulus. Pressure and touch and smell adapt. You've been sitting in your seats now for an hour, and you've been putting a lot of pressure on the muscles and on the nerves back there. I just adjusted your seat. You know, we adapt. We adapt to the constant pressure of sitting in one place for a long time. We adapt to touch. We don't pay attention to the clothing on our skin. You know, if we're not aware of, until I mention it, we're not aware of the tag on the shirt collar or our whatever we have on our feet, you know, or the buttons on our clothes or anything like that. We're not aware of it. We don't think about it. Are you aware of your hat? Not see, yeah, not much. We adapt to lots and lots of touch. We get used to it. And odors, we adapt to odors. We get very used to odors. I used to do a demonstration. I hadn't thought of it till yesterday. But, I used to take get a bottle of really, really cheap cologne from Walmart and pour it out in a beaker so it would fill the room with whatever the odor is. Okay. And after about an hour of class, we wouldn't notice it anymore. We would no longer be aware of it. And then I'd have somebody come in. Come on, I said, tell Dr. Grice, come down to the classroom around 2 o'clock and tell me what you smell, you know. And she'd walk in and she'd get knocked over by the odor because it was very powerful. You know, Walmart's best, $1 a gallon or whatever, you know. So we would get used to it. We would adapt to the odor. And someone coming in fresh would be sort of knocked over by the smell because it would be brand new to them. So we adapt to things like that. We often adapt to sounds. We get used to background noise. We when you're asleep at night, do you pay attention to the sound of the heating system running at night? Do you? Does it wake you up? Sometimes, but you sleep sometimes too. So when you sleep, you're not paying attention to it. You know, yeah, we're all like that. We still hear it, but it fades in the background. Our houses make all sorts of funny noises, and we're used to those. It's when the noises stop that we wake up, and We'll talk all about that in lecture, why that happens. The things that don't adapt are pain. We don't adapt to pain. We don't adapt to our position. We never get used to what body position we're in because we always have to be able to move. And we never adapt the chemical makeup in our blood. We always have to maintain, you know, not too acidic, not too basic, the right amount of oxygen, the right amount of salt, the right amount of water all the time. We're always adjusting that. So we can't adapt to any extremes. So we never adapt to that either. Okay. And I'll just, this is the last slide. Proprioception. It is self-awareness of our movement and our body position. Proprioception depends on receptors located in our muscles, in our tendons, and our joints. And they tell us when we're moving, how fast we're moving, and are we overloading our muscles? Yes.
I was just going to ask, when it comes to us standing still, do we adapt to some extent to the position of our body? Like if we're sitting down for an incredibly long period of time? Because I've noticed in the past, like sometimes I'll zone out so much that even just for a brief moment, I'll feel like I don't recognize the position of my body. It kind of jolts me.
Yeah, we can, to some extent, if you're sitting still for a long period of time or when you're standing upright, yeah, you can adapt to some extent with that.
Okay.
You aren't aware of it, but consider how much we move around at night when we're asleep. We roll over constantly. We're in constant motion. We're not aware of it, but you know, if someone were to film us or record us doing that, we would be moving around all the time. Even rapid eye motion when we dream, we never adapt. You know, our eyes don't just like go closed and stay closed and don't do anything. What the proprioceptors do, in addition to monitoring our position, they tell us how fast we're moving. And first of all, they tell us how fast we're moving. If we are driving a nail, are we gently tapping the nail in, or are we slamming it down? They tell us when we've overloaded what our arms or legs can do. If we go to pick up something very heavy, you're going to discover that you can't hold it and you'll have to drop it because we've overloaded what the limb, as they say, the limb can do. So our brain takes all this information and gives us a very accurate position of exactly where we are, what we're doing, and how fast we're doing it. So the idea is to protect us from doing too much. You know, how fast can you throw a baseball? If you try harder and harder to throw a baseball, as you get faster and faster, you're going to reach a point where you exceed what the muscles of the arm and shoulder can handle, and you can injure your arm. You know, we always hear about professional athletes, and probably at college and high school level too, throwing their arm out where they've overextended the range of what their arm is capable of doing when they throw. It happens. So our proprioceptors are trying to warn us not to exceed that. You know, we can work up to a new extreme, but to start out suddenly and say, hey, watch this, you know, which is why we have a warm-up phase when we exercise to begin with. So, okay, that's where I'm going to stop. Next week, we will continue with the general senses. You'll have a little more background on action potentials and nerve impulses by then. In lecture on Thursday, we're going to continue on muscles and move into how do we control our skeletal muscles and get them to do things for us. So, okay. Anybody have any comments or questions on anything? Okay, then I'm going to get us out of here. And I'll see you.
Just to sign the paper.
Oh, yeah.